just past 12 noon on April 5th, and we're very glad to see all of you here for the CMDA monthly meeting. Today we have a great agenda with great speakers, and we can go ahead and start with our updates. I have Chad Fear listed first. Do you mind going first today, Chad?
Sure, that's fine. I don't have a whole lot for you all today. Just wanted you to know that we continue to work on our backlog of complaints and revisits. We're working on strategies to get those caught up. So you may see us in buildings more and more frequently as we try to get that work done. Excuse me. We had a great meeting. I think it was a great meeting yesterday with the community to discuss abuse and neglect issues. Enjoyed the chance to actually get together in person and have some dialogue, and you know, picked a real simple subject to do that. We continue to work with reworking our training activities in response to the number of openings that we have. We see that there's going to be, from meetings with CMS last week, there will likely be a greater emphasis placed on systems issues surrounding health and safety. So taking on, you know, looking at some of those bigger impact areas. We are waiting on guidance that's soon to come for the 2019 phase 3 changes that were placed on hold due to the the onset of the COVID pandemic. So we're waiting for additional guidance there. And then we'll have those conversations to see how we're going to survey to that. And, you know, we're spending a lot of time right now also sorting through the changes to the residential care facility mitigation guidance, and that's been provided by CMS, particularly around, the description of vaccinations as folks being fully vaccinated versus up to date, and how that affects residents and staff in facilities, and how we'll move forward with that. So pretty much that's what I have for you today.
Thank you so much, Chad. Is there anything we should watch for in terms of those phase 3 changes that you said are coming up?
You know, no, I think we'll be able to speak to that with with more accuracy when we get closer to the time that information is provided.
Sure.
So nothing alarming right now.
Thank you. Well, next we have Jenny Albertson with CHCA. We're ready for your updates, Jenny.
All right. Well, this is an extremely exciting morning because we have a reduction in testing requirements for COVID. So I wanted to touch on that. The update to the mitigation guidance that we got last on the 28th of March has now been updated again, effective the 4th of April. And the main changes are in the point of care testing requirements, which is one area where they had some discrepancy ongoing with CMS and CDC guidance. And so it's lovely now that we are in line. There's still just a couple of divergences, and I will outline those very quickly for you. First of all, the updates on the testing table include the following: asymptomatic healthcare personnel with a high-risk exposure who are up to date. They don't have to quarantine for quite so long now. That's now been lined up with CDC, so it's a 7-day period, not a 14-day period for that high-risk exposure. Residents with close contact to someone with COVID, it's now a 7-day quarantine, so that's lined up as well. And that's because of, and no POC testing to go with it. Newly admitted residents, they've reduced that as well, from no POC testing to the 7-day requirement for quarantine exclusively. And that also goes for people that have been out on passes over 24 hours. And then routine surveillance for healthcare personnel who are not up to date when we are in a moderate transmission level. That was exceeding the regular guidance from CMS. It used to require a POC test, which was what they implemented when we had Delta variant. Every time they would come on shift, now they've withdrawn that. So now you only have to do the POC testing for incoming healthcare personnel when they come on shift that are not up to date. I feel like this is such a mouthful. Every time you're in substantial to high, but anything below that, you do not have to do that. They've added vaccination reporting weekly to EM Resource, so that lines up with the NHSN reporting, so that's in conjunction now. And they've also added clarification on what's required for booster clinic offering. So before it was just kind of this broad sweeping, make sure you educate and offer, and it was like, well, when are we going to actually get in trouble if people are not taking it and whatnot? They still have not changed the Chapter 2 guidance, like what Chad just referenced. The Chapter 2 actual guidance for mandate for vaccines still is not the up-to-date terminology. It is unvaccinated and fully vaccinated. So you won't be seeing people fired for not being boosted. However, they are requiring us to offer clinics every time the CDC updates their recommendations for boosters within a 60-day period of that recommendation. So we now understand what's expected of us. That is so nice. So that's lovely. And I just sent to Dr. Pallett my updated testing guidance diagram. So you have a quick reference for your facilities that I would love to use for CMDA and not just for our members. So please feel free to do that. And there is a reference on the Ko-fi blog for the vaccine clinic guidance on how CDPHE wants to support us in that. That's exciting. And just the divergences that I referenced earlier, there is now a little bit of a difference in what CMS and CDPHE are asking for with determining community level of transmission. CMS says check it every 2 weeks, and CDPHE says we're going to upload it to our own site every week, every Friday, and that's what you're supposed to abide by. So go ahead and do the weekly. Always go with the more stringent. And CDPHE is posting that on their community levels of transmission section on their site, and I will put that in the chat.
Thank you so much, Jenny, and thanks for your work on making the testing requirements much more simplified in your one-pager, and I'll be happy to send that out to our members.
Wonderful, thank you.
Are there any questions for either Chad or Jenny?
Chad, can I ask, this is Leslie, what are the tags that you're seeing these days? What are the most common?
Yeah, so I think we continue to see, issues around pressure wounds. We're seeing citations, of course, for infection control issues, accidents. We're seeing perhaps a decline, but we do still continue to see issues with nutrition, and we're certainly seeing issues with ADL care for dependent residents. And I think you can look at those care areas where there's a correlation between staffing and the ability of facilities to provide staffing sufficient to meet care, and you really can see some relationships there. We try to keep the focus, if we can, on the care area itself, but we do find instances where we are citing staffing when we see that there is a pattern and it appears to be more of a systemic issue where there's sufficient practice with care, maybe perhaps across multiple areas.
Thank you so much.
You're welcome.
Yeah, thank you for addressing what is definitely a universal challenge with staffing everywhere. So, all right. Any other questions? Now we can go ahead and turn to our first clinical presentation today. This is going to be with Dr. Cari Levy. She's a professor at the University of Colorado and the section chief of palliative care medicine at the VA Medical Center. Dr. Levy is going to talk to us about the PALTC-KNOW network. Thank you so much for presenting today. I know we had hoped that you would present last month, but we ran out of time.
No problem. Can you hear me?
I can hear you.
Oh, excellent. Excellent, excellent. So yes, thank you so much for the opportunity. If at any point you can't hear me, this headset for some reason has been a little persnickety. Just stick your hands up and wave or something, and I should see you doing that. So can you see the slides?
Yes.
Excellent. Okay, so I thank you for the opportunity to present today. This is about a network we're just starting to form, and it's been a few years in the making, but was hoping to present it to you all, get your feedback and input as we move into what I think is an exciting phase. And so the network is called the Post-Acute and Long-Term Care Knowledge Network for Older Adults and the Workforce. And the idea is to begin to facilitate a more natural relationship between frontline staff and researchers, because we know the best ideas come from the front lines, and the hope is to create a portal really for creating that connection from long-term care staff and researchers. So it's called the PALTC-KNOW, and you might hear people saying, be in the know, get it? Be in the know. So knowledge network for older adults in the workforce. And so what I wanted to do is just tell you a little bit about it. And I wanted to start by asking you if you could put in the chat what one word comes to mind when you hear the word research. And I can keep a little eye over here on the chat and give you a moment to do that. Innovation, data, and you can put scary words in there too, if scary words come to mind. Hopefully they don't. But go ahead and just continue to put your thoughts in there. When we started this, we were worried that advancement, awesome, lab rats, lab rats, yes, indeed. When we started this, we were worried a little bit that frontline staff would hear the word research and go, oh no, that sounds, scary, more work for me. And so we interviewed frontline staff, and you'll hear about that as we go. And the folks that we interviewed anyway were really excited about the opportunity to be in the innovation space. And yep, I see hard work, Meara, thank you for that. And excited to contribute to solutions. And so I think this is one way we might begin to engage people in a meaningful way, create some career ladders for folks, and help them feel really valued, and to retain our staff more effectively. And so the next question I have for you is if you can put in the chat from 1 to 5, rate your level of agreement with the following. Research can improve the care I provide. 1 is strongly disagree, and 5 is strongly agree. And then if you're somewhere in the middle, great, thank you all. Hey, Amy. Hi, Chris. Great. So it looks like most of you really feel strongly that research can improve the care you provide. And that's really the idea here, is that we're doing research that's meaningful and that really is improving care and isn't taking 17 years to get to the field, which is the number, of course, we all hear with regard to research improvements. So what the vision is for this network is a network of experts, all of you, all of the people you work with, focused on meaningful ways to enhance the joy of life and work in our post-acute and long-term care communities. And this is where we're going to have to go in order to engage people in this work that's becoming increasingly difficult, and where we're having trouble retaining staff and recruiting staff. So collectively, the workforce is our providers, our residents, our caregivers, and we're beginning with you all, with the experts in this care, and then ultimately hope to expand to residents and caregivers. So I'm going to show you just a little 3-minute cartoon here, which I think is helpful in understanding what we're up to. Can you hear it? Can't hear it?
I don't hear the sound.
Oh, shoot.
Share
Okay.
computer sound.
Okay, let me stop it. How do I share computer sound?
When you share your screen, you hit share screen or new share screen. There's an extra button for sharing computer sound.
I see. Do I have to stop sharing?
Maybe.
Oh, here we go. Let's try this. Okay, let's try this. If it doesn't work, that's fine. I can just tell you what it does, but it's pretty cute. So I want you to see it. Okay.
Excited you're here.
Better?
We are an interdisciplinary group of researchers and clinicians at the University of Colorado.
Oh, and then I stopped it. That's
We're
my fault.
excited you're here. We are an interdisciplinary group of researchers and clinicians at the University of Colorado. Collectively, we have a deep commitment to improving care and quality of life for older adults and those who care for them in post-acute and long-term care settings. This video introduces a post-acute and long-term care knowledge network for older adults and the workforce. We are calling this network PALTC-KNOW. The idea behind this knowledge network is that we have a group of experts who are focused on meaningful ways to enhance the joy of life, and importantly, the joy of work in a post-acute and long-term care. Collectively, we envision that our workforce, providers, residents, and caregivers make up the experts of post-acute and long-term care. To start, what are the inputs that come together in this knowledge network? The essential inputs are dedicated staff, as well as post-acute and long-term care researchers. Next, what is the knowledge network? We envision this as a safe space where we can collaborate and be creative. We want this to be a playground where we can focus on making care and work meaningful and also emotionally uplifting for our colleagues in post-acute care and long-term care residences. Finally, what kinds of things might the knowledge network produce? We are hopeful for several key outputs. One idea is multi-facility quality improvement projects. We're all doing QI projects. We're required to do QI projects. So why don't we collaborate across facilities and be inspired and informed by our peers? Another short-term output might include research that's focused on what matters most to the network. There's a similar network in the Netherlands, where ideas come from those on the front lines, those at the bedside, and then researchers help with the details of implementing those great ideas. And that's what we're hoping for from this knowledge network. Good ideas come from the bedside. Good researchers who care about this work and expertise to implement it successfully. We desire to foster a network of community providers who are able to bring evidence to older adults and caregivers. Our long-term vision is that we spark joy. We have happy residents, we have a happy workforce, and we sustain this expert network for ongoing partnerships with researchers. For example, when a frontline staff sees a good idea at the bedside, you can share that with someone who can then help with research and implementation. We also hope to promote the value of good work in post-acute and long-term care. So, when we get calls from reporters who want to talk to those at the bedside and understand what's meaningful about the work or what's hard about the work, then our network can share stories about why this work is so very important. Finally, we also have legislators who really want to help. How can we have them help us in actually helpful ways? This knowledge network can be a resource to influence health policy. In summary, we envision this PALTC-KNOW network to be made up of people who care about the quality of life and quality of work in post-acute and long-term care communities. We see it as a way to be inspired by peers who promote good ideas. Ultimately, we have a shared passion and a deep commitment to the care of our post-acute and long-term care communities and colleagues. Please join PALTC-KNOW, a knowledge network for older adults and the workforce. Thank you.
Great.
We're excited you're here.
Oops, we don't want to
We
do
are
that
an
again.
interdisciplinary-
Excellent. So thank you all for listening to that. And that's really the background for all of this. I also wanted to just ground us in some of these statements that we heard from frontline providers when we went to interview them about the heart of what they do. And I'll read this first quote, which is, "This isn't like a factory production job. This is human care. I feel like the element of human care gets lost because we have to be so task oriented. I try to organize my tasks as much as I can, as quickly as I can, so I can spend my precious moments with being who I'm around, because the rewards of working with the elderly, the love they give you in return for the love that you give them, is profound. I feel like that's what keeps people there. But it does. It creates an element that you can burn yourself out very quickly because you don't get your cup filled to the point you need. I feel like that's a lot to do with why we have such a shortage." So really getting at so many elements of what's important and also why this is a bit of a struggle. And so really what's fun about this is there's a big push right now in the research world to move from the traditional, very strict enrollment criteria, very controlled circumstances, to, at least in our world, pragmatic research that's going to have meaning once it leaves the research space into clinical care, because it was done in places that are just like where you practice. And of course, in the past, what we've managed to do is recruit the highest performing nursing homes to do research. And then when we try to move it out into a more typical setting, it often, in fact, almost uniformly fails. And so what we're trying to do now is be much more pragmatic, make sure that eligibility is quite general and really includes everybody we possibly can who lives in a nursing home, not just the cognitively intact or just the high functioning individuals or those with high functional ability. We want to recruit in a way that's very inclusive and not exclusive, which of course has been the way that traditional research has gone. And so you get the idea that we want to be flexible, but also be aware of those flexibilities so that the results aren't just a mess. And here's an example. I think this is a nice chart that shows you, a typical explanatory trial where we want to know, does the treatment work? Is it efficacious? You're doing this under ideal circumstances. And the example here might be the effect of a drug. So we're assessing the cause or the effect of the drug. We have a very rigid protocol, rigid inclusion, exclusion criteria, and data collection is very regimented. And this is, relevant to outcomes research. What we're doing in pragmatic trials is we're looking at the effectiveness. What's the treatment strategy that will allow this treatment to be effective in normal circumstances? And we're maximizing generalizability, broad inclusion criteria. Ideally, you're enrolling a whole facility. You're not just enrolling people within the facility, but you're really providing an evidence-based practice to the entire facility so everyone has the ability to benefit from it. And some of the domains that we evaluate this type of research in the implementation science world is it reaching the target population? How will we know it's effective in this typical population? How do I develop organizational support so it's adopted and it's not just sort of an awkward, clunky thing that's inserted into typical care? How do you ensure it's delivered properly? And this is really the big area, is the implementation piece and trying to figure out how to do this well in our very complex environments. And then how do I do this over the long term, which is of course always the holy grail. The little video you saw mentions that this started in the Netherlands, and this is the conceptual framework that Hildy Verbeek developed for their living lab for aging research. And the idea here is you have 3 pillars in the middle, the quality of life, quality of care, quality of work pillars. And then in between, you see these blue bars, which are the foundational elements of care and support, staffing and innovation, and redesign of care. And at the bottom is the quality of education. And I think of that as kind of the fertile soil, growing, new ideas. And then the quality of research, kind of shining a light on those new ideas and helping get data that will allow us to implement effectively. So when we interviewed frontline staff, our objective was to ask them how to make research in nursing homes meaningful. And we interviewed staff from March to July of last year. We had 14 folks who participated: RNs, LPNs, dietitian, social worker, staffing coordinator, unit manager, dining services director, activities director, director of nursing, and then did some thematic analysis around that. And I won't go through in great detail all the analysis, but it really aligned very nicely with that conceptual framework that Hildy developed, in that there were, of course, many themes related to care and support, making sure that care is patient-centered, that there's continuity of care, that the patient-to-staff ratios support a healthy amount of care, and then addressing loneliness. As far as staffing went, this quality of time theme came up a lot, where people go into this because they love being, you heard that in the quote, love being with our residents, and they want to be able to do that and not be so rushed and so focused on tasks. Valuing of frontline staff, we hear this again and again in all of the staffing workforce shortage research that's going on. Having a collaborative relationship with management and having management part of the daily work as opposed to often an office isolated from those who are doing the daily work, teamwork, communication. And then also you'll see a lot in the workforce literature, and we certainly heard it here, that there need to be training opportunities and a ladder so people feel like they're progressing in their careers and adding more skills and training so they don't feel stagnant. As far as redesign of care, really coming back to things, you know, we've heard for many years, which is a sense of home, a sense of community, and autonomy. Making sure that training goes beyond just tasks and people know why they're doing the tasks that they're doing, and then really basing staffing models on fluidity, wraparound services for staff so that they don't have to work multiple jobs. They can really work one job and be compensated well and cared for well in that environment. And then supportive and more flexible rules rather than more regulations. We just keep getting more regulations, and of course that's not going to make it any easier or likely any better quality care. As far as quality of life, I just love this quote, so I have to include it. Again, just to get us back to, you know, why we do this and who's doing this right now alongside us. People don't want to leave their houses because they think like nursing home is just like putting them in a dumpster. That's the way they see it, which is not good. There was one woman, she used to take care of her husband at home. Finally, she couldn't. Then she came to us. I think it was as hospice. Then one day, his wife was sitting. What I did was I sang. I don't even know how to sing, but I sang, "You Are My Sunshine." "Mr. Green, let's go sing." The patient, he sings. He doesn't even talk, but that day he sings. He sings with me. The wife was kind of, "Well, you don't know what you're doing," she told me. And my goodness, I thought, I'm going to get fired now. I was thinking, what is she going to say? Maybe I did something wrong. I'm not supposed to. She was in an angry state, but putting him in a nursing home because she used to take care of him for years. Then she said, she cried and she said, she gave me a big hug. "He doesn't even talk or call me my name, but you make him sing the song." Then she said, "I want my husband to be your patient." We had a good time. He died very happy. Even he used to eat for me, and she was pleased. Now, what I'm trying to say is if we have good mechanism financially, good nurses and staff, nursing home could be a good home for patients. And just beautiful, just beautiful. I love this quote. And you think, gosh, if we could set this person up for success and allow them to thrive, what beautiful things could happen each day. And then I believe this is the last quote, which is related to quality of care. Yes, most thing I see when they're in the nursing home, just mostly you want to help the patient. But most things just lead to a push or two on the paperwork. Instead of more patient care, you force it to lean to the paperwork. I know we try as much as we can, take care of the patients, but in the back, waiting for us, we have to deal with all those paperwork, charting, everything. Still, I understand it's necessary, but those things always bothering me. Instead of giving more time to the patient care, just leading to the paperwork. That's the more, always just bothers me over there. And so, you know, one of the missions of this PALTC-KNOW group is to improve the quality of work, to get people back to the bedside. And this, I thought that was my last quote, but here's another one. So basically, same theme about charting and not being able to do the work that they want to do. And so as we look at these interviews and the themes that the knowledge network conceptual framework includes, you really see some very concrete ways we can speak to the frontline staff and generate research about how to allow them to do that more effectively and more fully. So we've got the care and support theme, feeling at home, making sure we're creating a patient-centered environment, the staffing theme, ability to attract good staff, valuing them with fair compensation and career ladders, and then the redesign of care with more supportable and flexible wraparound services. So a couple of additional quotes here around each of those themes, and then I'll just read the one that's up on the right, top right, which is, we need to participate in research. For me, I'm so glad to meet and talk and share what I feel, what I see, what I know. The purpose is very important. If you know the purpose, if that purpose is yours, it's a must, I would say. And this actually ended up being the title of a talk we presented at AMDA, or workshop we presented at AMDA. If the purpose is your purpose, research is important. So again, you just so strongly see that people very much want to participate. It's not a scary thing. It's a quite a motivating and uplifting thing to think about participating. So what are we doing to advance this group? We're just in the beginning phases. We're trying to create what they have in the Netherlands, which is 6 different of these labs, partnering with facilities and academic centers to really put research into action and do that in real time. And so we've now had a couple of different workshops about this. We're putting all that data together. And one of the things that's come out of this is working with CareAscend. Some of you might have heard of CareAscend. It's an app that I'm showing here on the right. And let me just go to the next page. Here's the website. And you can see this is an app that was originally designed to allow medical directors to track their time and what they were doing with their time for reporting purposes. And now it's continued to expand to be a communication platform, to show a performance dashboard. And back here, you can see that here's the contact hours for this particular medical director and what they had done in order to achieve those contact hours. And so it's a very user-friendly app. And our next project is to put as one of the features on here, research. So people can click on that. They can say, hey, I'd love to participate. I'll be happy to do a survey. I'll be happy to submit some data about, let's say, my well-being throughout the day, whatever it is that they want to participate in, they can opt into that. And so we'll create a registry. And the idea is that we get a big registry of all sorts of different staff members, frontline, CNAs, RNs, LPNs, dietitians, physical therapists. I was meeting with a physical therapy researcher yesterday who is hoping to enroll folks through this type of app who want to deliver some of the interventions that they are working on, high intensity rehab and that type of thing. And so the idea here is that we've taken the ideas from many of you, and we're trying to put those into action, get this network together, and then just let the researchers go to town and access folks who are interested in participating and allow their ideas to bubble up from the field, and then work with implementation scientists to make that reality. So this was from one of these workshops a couple of years ago. And some of the solutions they came up with, which I thought was so cool, they used the acronym HOPE, harmonizing and integrating a value-based suite of services. The O is for objective data that's fed back in real time. The P is for person-directed goals to serve as drivers of new models. And the E is engaging relevant stakeholders at all stages of design of research. And so my sense at this point is we're now having, we've had more and more of these workshops. We've got a good solid foundation, and now we're ready to engage a lot of folks in this work and connect researchers. And any researcher you talk to who wants to do nursing home research or long-term care research will tell you one of the main barriers is recruitment. How do you get access to these communities? And our hope is to kind of transcend the affiliation with a particular practice or building, and really allow people to participate of their own will and contribute in that way. So if you're interested, you can email me. I'm at the bottom there, carilevy@va.gov or carilevy@cuanschutz.edu, assuming you can spell Anschutz, which I still struggle to do. But or Kate Yattel is our program manager, who's just been terrific, and Catherine Nearing, or Katie Nearing, works at the university and has helped a lot with this. So if you're interested, then please let us know. Hopefully in a few weeks, months, I'll be able to ask you to download the CareAscend app and click on the research feature, and that way you can participate and get notifications about when research projects are being done. And the idea is that these are bite-sized, that they're involving real-time data, so you don't sort of agree to participate and then 3 years later when the grant gets funded, they reach back out to you. And then 3 years after that, when the results are available, they let you know what the results are. The idea is for this to be almost like a QI rapid cycle type of project, where things are moving and not so traditionally stuck as much research can be. So I will stop there. I thank you very much for the opportunity to present. We're eager to get your feedback. So if you have thoughts as you're listening to this and want to send those along or put those in the chat, that's great. And I see in the chat residents often get very excited to participate in research. And yes, we're starting with the staff to keep things somewhat tight early on, but then eventually, absolutely, we want to open it up to caregivers and families and residents who can also participate in this work. So thank you.
That's really great work, Cari. Thank you for presenting it to us. And just so everyone knows, Dr. Levy will also be presenting at our CMDA annual conference in April. We look forward to that. Are there any questions for Dr. Levy right now? Are there some immediate opportunities where you need some people at the moment?
Absolutely. So if you wish to get involved now, just email me or email Singh or any of us here, and we'll get connected. And you do not need to be a med director. The hope is to have physical therapists, occupational therapists, speech therapists, RNs, LPNs, CNAs, the whole range of disciplines across long-term care. So we're hoping to include as many individuals who wish to participate. So the opportunity now is to let us know you're interested, and then we'll begin to share some events with you. Like we're doing a food truck event where we're going to take food trucks to a nursing home row where there's 3 nursing homes, and learn about people's interest in research and some of their ideas from the front lines. That'll be later this month. And then we have workshops that we're doing, and we'll have some community events to start to enroll folks. If you want to be involved in the development of the app, now's the time, because we're just getting that going. So really anything that hits you as exciting and gets your juices flowing, we'd love to have you involved.
Are people compensated for the research that they're doing?
They can be. It depends on which study they participate in. We have a number of advisors who are helping us right now who are being compensated by a grant and helping put this together. And then the idea, of course, going forward is that you would be notified that there's opportunities to participate in studies, and then you can consent to do that, and then have a stipend related to your participation. So I think it will be a variety of different opportunities, and that folks can commit what they've got the room to commit to. Consultant pharmacists, absolutely. We anticipate there will be a lot of interest from industry, and initially well-being apps are very interested in learning whether this is a population they can impact in a positive way. So some things like Headspace, if you've ever heard of Headspace, it's an app that helps with meditation and mindfulness. And so there's a couple of industry, if you will, groups interested, but of course, pharma is always interested in getting consultant pharmacist's opinion and engagement. So everyone is welcome. So the best way to contact, let me put in the chat my email.
Appreciate that.
You can just reach out to me directly.
Thank you.
Yeah, thank you.
Thanks for bringing that opportunity to our audience. And I think you meant that you don't have to be a medical director, but you could be a medical director, and you could be a physician assistant or a nurse practitioner or someone else working in our space. Yeah, thank you. Well, why don't we let our next speaker get ready, and you can get your slides up. Dr. Mira Melton is our next speaker. And just a couple of weeks ago, the AMDA annual conference took place. So it was more than a couple of weeks ago. Yeah, it was in Baltimore. And I had the chance, great opportunity to meet Mira. She's a fellow at the University of Colorado studying geriatrics, and she'll be graduating later this year. And she actually agreed to do the AMDA pearls for us this year. We really appreciate it.
Great, thank you so much. I'm excited to share a few of the pearls. As you all can imagine, it's a multi-day conference, so we had to pull out a few things, but myself and your CMDA leadership came up with these few pearls to share. Before I start, I just want to thank CMDA for the opportunity to go to the conference. I was part of the Futures program. So if you haven't heard about it, it's an opportunity for trainees to go and learn about the post-acute and long-term care setting, meet other trainees, and it's not just geriatrics fellows. So there was an OT there. So I think I just wanted to put that plug out there. So if you all have any trainees who are interested in it, it's an amazing opportunity, and I just absolutely loved it. So we're going to jump into a few pearls. The first we're going to talk about are some that relate to clinical medicine. And we felt like the year in review that covers a few studies was an important place to start. So these studies, you can look into some more of the details if they're of interest to you. But first of all, there's this study that was published in September of 2021 in Cmda, and they looked at, they gave residents 2 bottles of a high nutritional supplement for 3 months, and then looked at both nutritional and functional outcomes. And so they found that there was an increase in body weight, about 5.7 pounds or 2.6 kilograms on average, increase in BMI, and then also some functional status things. So they looked at gait speed, a measure called the Barthel Index, and they saw some small but significant improvements. So when you're ordering these supplements, now we can say maybe there's actually some benefits that were put into in writing here. Our next pearl was a study that looked at slowing. Is this a new vascular geriatric syndrome? And so what they called slowing is slow gait speed, slow cognitive processing, and apathy. And essentially looked at, and found that gait speed was associated with a decreased processing speed or thinking, and increased symptoms of apathy. And then they associated these, the levels of gait speed, cognitive processing, and apathy to brain imaging, and saw that there were increased white matter hyperintensities on imaging that were associated with all of these things. And so had proposed this maybe some, a new geriatric syndrome we might be considering in the next few years. The next study went over this newer study of pimavanserin or Nuplazid, which you all may know from the Parkinson's approval several years ago, but showing that patients with dementia-related psychosis that had a response to pimavanserin, so they gave them pimavanserin for 12 weeks, then they did a study looking at continuing pimavanserin or stopping it, and looking at the risk of relapse with continuation of the drug, and found that relapse was higher when they discontinued. And I want to put a plug out saying that the pearl is it's not likely to be practice changing based on the study, because the efficacy of the pimavanserin itself in this area is not really well established, and there were a lot of adverse side effects that were also in the study. So, but it's still being studied, and it was in the New England Journal, so something to be aware of. This is kind of a fun one, looking at doll therapy as a viable non-pharmacologic intervention. Essentially, patients who have dementia and also have behavioral and psychologic symptoms were given either this doll seen in the far right, that's from the study itself, and they compared it to standard therapy and found decreased agitation and aggressiveness, decreased symptoms like wandering and apathy, and then also found that there was decreased caregiver burden and incidence of delirium in the patients that had the doll therapy. So, we've heard about this, but this study kind of establishes it as a good non-pharmacologic intervention that we can consider in our facilities. They also reviewed the antibody therapies for Alzheimer's disease. You may be familiar with aducanumab or Aduhelm and donanemab, and those two, they looked at the study that from the New England Journal from donanemab, and then also looked at the approval with the FDA. And essentially, the take is that they show clearance of amyloid in patients with mild cognitive impairment, but have failed to show meaningful clinical benefit yet. And it's high cost and has high potential side effects. And so this is taken, below here I have the statement from AMDA essentially saying, that we're not recommending it yet in nursing home residents and population. So an important thing to be aware of. And then this is from one of the small groups that looking at cannabis use in older adults. And the pearl here is that older adults are using cannabis, and less than half of them are reporting it to providers. So essentially, we need to be talking to patients about it and educating ourselves. From that presentation, they had done a poll in the older adult population, and only 41% of users reported their use to providers. And then 61% had used cannabis for the first time, and then 55% had no plans to reduce or quit. So something we should have on our radar and be thinking about how we're going to approach with our patients. There was another small session that, presented considering race as a social construct and not biologic. And there are several clinical tools that we use on a day-to-day basis that include race and maybe adversely impacting our patients. So something to be aware of. Each of these that are listed here below from that presentation include race as a factor in these clinical calculators that we may often use. And kind of 3 highlights. So when we're looking at the estimated glomerular filtration rate, both the MDRD and CKD-EPI equations are reporting higher values for patients identified as Black, which suggests a better kidney function than they may actually have. For pulmonary function testing, there are correction factors for Black and Asian patients, leading to inaccurate estimates of lung disease severity. And then for the FRAX score, Asian, Black, and Hispanic women risk is estimated to be less than white women with the same risk factors. So things to keep on your radar. There are a lot of discussions about how these are going to be adjusted, but just know that these may be impacting the scores we get for our patients. On a goal concordant care conversation small group, some pearls from that include 1, asking what brings them joy or sadness. So what really matters to them. 2, practicing cultural humility, which means, being willing to learn from them and their experiences rather than, presenting yourself as an expert, and really understanding that the cultural aspects of their background. 3 is acknowledging emotions and responding with silence, even let it get pretty awkward with the silence, which is hard for all of us. And then I think the final pearl from that session was that code status is a really small part of the care plan. So thinking about all the other things that go into creating a good care plan for a patient. A couple of things on operations. So a couple of pearls for QAPI. 1, doesn't necessarily work with the spray and pray method, where facilities spray education around the building and pray the outcomes improve. And so the recommendation is to instead, look around, ask people what's going on, ask them where things need to be worked on, implement something, then bring everyone back together and get feedback from them, and really try to study the processes, look at the data. And of course, putting this into action is always hard, but that's another kind of ongoing pearl. And then considering doing QAPI as meetings as walking rounds, so you can really get to know what's going on in the facility. Another pearl from a couple of sessions is considering developing a sexual expression policy if there isn't one already in place that reflects the culture of your facility, and to educate your staff and share that policy with patients and families at the time of admission so that people are all on the same page. A pearl from one of the transition sessions is to shift our thinking from, is this patient ready for discharge, to, is this patient ready for the 2 weeks after discharge? So we know that transition period is not that the next day everything's going to be in place. So kind of changing our thinking process, what things need to be in place for them to be successful for a little bit longer period of time. And then on the policy front, some of the pearls here, people may be wondering about the telehealth codes. So telehealth for initial visits is currently not included in the covered codes after the public health emergency is over. And this may change, but it's important to note that now, and hopefully we can give updates if we find out that changes at future CMDA meetings. And then the subsequent care codes are permanently on the list of Medicare telehealth services. But as of now, when the public health emergency ends, we may only be able to bill these codes once every 14 days again. So something to be aware of as hopefully we get closer to the end of the public health state of emergency. Another pearl noting that California has now mandated a CMD for all facilities as well as a public registry for all of their facilities. So just knowing what other states are kind of doing in this area. And then we wanted to kind of summarize AMDA's take on President Biden's proposal for nursing home reform. So AMDA looks forward to working with the administration to help with nursing home reform. It wants to strengthen the workforce by ensuring a safe environment, providing adequate compensation and benefits, providing training and career advancement opportunities to staff members. It supports the proposal of owner transparency. It supports the medical director and provider training. It promotes technology to provide better interoperable communication. And in response to the proposed staffing minimum, AMDA promotes the essential shift to elevating the respect and value society places on professionals who work in post-acute and long-term care settings, including frontline staff and providers and the vulnerable patients that they serve. And AMDA also reiterated that the adequate compensation and training are necessary before we can, before staffing minimums can be possible. So kind of the take on the nursing home reform proposal. And then last but not least, wellness, because that was a huge theme at the conference this year. So as far as caregiver wellness, if a caregiver says, I can't remember the last time I did something for myself, we should be considering screening them for caregiver burnout and finding ways to offer support. Another pearl is to consider how you can play a role in the staffing shortage and also burnout. So can you adjust medication administration schedules to make it easier for staff members to not have to, be constantly administering meds? Can we decrease vital checks on those patients that are pretty stable? So those are kind of small things. And I have this little light bulb with creativity loading, because I think there was a lot of talk about how can we be creative in this space and do a better job of just helping all pitch in for the staffing shortage. Another pearl is that music continues to be a way to connect and show empathy. It leads to benefits for residents and staff. Dr. Levy's presentation had that quote about singing, so we know firsthand that's important. And then the last pearl, I think, is that the work that all of you all are doing is extremely appreciated. You guys are all amazing. And there was a big thank you and shout out to everyone at the conference. As trainees, we recognize everything that you're doing. So thank you all so much. And thanks for the opportunity to share some of these pearls with you.
Well, that's how you summarize a 5-day conference in 20 minutes. Thank you very much. Does anyone have any questions for Dr. Melton? Great. And do you mind if we send out the slides to everyone?
No, absolutely. Please do.
Thank you. Thank you. We have a few minutes left, and I'd like to transition to Travis Neill. He is one of our CMDA board members. He's going to give us an overview of the CMDA conference coming up in April. And two things I hope that Travis will definitely be stressing. And one is that people do have to be vaccinated and boosted to come to this conference. And with those precautions in place, we are going to be recommending masks and recommending that people keep masks on when they're not actively eating and drinking. And the second thing, and I think Travis will touch on this as well, but we are still collecting contact information for CMDA members that are retiring this year. So if you know somebody, please send their information our way. Okay, go ahead, Travis.
Thank you, Dr. Pallett. And thanks, Mira, for the update from the conference. That was great. So yeah, just to start off with reminding everybody that this conference is on Friday, April 29th. So it's coming up really quick. And the last day for early registration is April 15th. So important, you'll get early bird pricing if you register by April 15th. So you can register at cmda.us. And, the reminder that it's a all day of relevant education with both local and national experts. And with all the things that have been facing long-term care for the past couple of years, it's not only a chance to get really valuable and useful, relevant information. The cost of the conference relative to most single-day conferences is on average about 50% less. So it is really a value for your money. And it's also a chance to see people. So, for us that have been really isolated for the past couple of years, it's a chance for us to actually see us in person and see who has the most new gray hairs after 2 years and working in long-term care during a pandemic. And then, along with that, for safety, just like Dr. Powlett said, we are requiring full vaccination for everybody, including boosters. And it would be helpful, and you can see this at cmda.us if you email that information ahead of time. And there's an email address provided on there. And we'll also have on-site security for any presenters that tell bad jokes so that they don't get slapped. So it will be a very safe conference. But if that's not safe enough for you, we also offer a virtual option, and you will get CME credit for either option. And just kind of a little sneak peek to the conference, some of the things that will be included in there. You just listen to Dr. Cari Levy, who will be presenting on innovations in long-term care, as well as Dr. Arif Nazir, both former presidents of AMDA, both national speakers. We'll also have 2 talks by Dr. Leah Watson on psychosis in late life and dementia. And as we all know, those talks are always incredibly useful. And then a panel on wound care, just like Chad mentioned earlier, that pressure wounds and something with infection prevention are pretty high on the tags right now. So hopefully some helpful information for that. And then breakfast and lunch are included, and there's a short happy hour immediately following the conference. Also this year, for the first time for long-term care pharmacists, the American Society of Consultant Pharmacists will concurrently host an event with the CMDA conference, and that's led by Chad Wars, who will also be presenting at our conference. So, it's really just a reminder that this conference, we are trying to design this to be for everyone in the long-term care space, all the professionals that touch this space, and so I think there's a little something for everybody. And so for people that that have never been to this conference, please spread the word that this is a way to really feel a little presence in this space, to a reminder that we're not alone, that there's a lot of us that touch these patients in this space. And so this conference can really, if nothing else, to be around other people who are really engaged in trying to make the space a better place to work. And so we hope to see everyone there in person or virtually on April 29th. So again, April 15th is the deadline for early bird pricing, and cmda.us is where you go to register.
Thank you very much, Travis. You're making me excited for the conference. And you should know all of our board members are working really hard to put this together, and we appreciate everyone's efforts. And we look forward to seeing you all at the annual conference. Thank you for joining us today for our monthly meeting. I will go ahead and stop the recording because I always forget to do that. And we welcome any other questions that you may have for any of our speakers. Thank you for joining us today.